well.
So I wanted to ask you guys a little, just stepping back from the ECMO discussion for a minute, just to kind of just go way back and think about kind of the nuts and bolts of a typical case. And you've mentioned a little bit of that, you know, in terms of like this happens at day 14, this happens days 5 to 10. But if you guys can think about the patterns you've been seeing, and first of all, like what are the thresholds to go to the ICU? You mentioned, Samir, about intubation and trying to be aggressive at extubating. The counter argument I've heard to that is each time you do an intubation, it's another aerosolizing procedure and more risks. And then the risk of being on high flow, and is that generating aerosols? So a little bit also about what you're doing for PPE in all these instances, and kind of balancing those different risks, and really just kind of taking us through the typical clinical course.
Yeah, so we've tried to standardize a lot of the process around the units. I mean, it's still vastly different if you're on the CCMU team versus anesthesia team versus the pediatric team, but we've tried to do a pretty good job of like, this is our anticoagulation algorithm, who's going to be on heparin drips, how we're going to transition, what values we're going to follow. We typically have been following anti-10As, what drugs we're using for sedation. We've tried to avoid benzos. There's a huge amount of delirium associated with it. There is a Ards algorithm that we've then started to use amongst the units to try to have some consistency. Because as you can imagine, we now have patients in the surgical ICU, the RICU, the regional isolation unit, the sister unit that we just formed now that's going to have up to another 50 beds. The PACU has been converted to an ICU on the adult side. We also have beds in a step-down unit that's become a full ICU unit, as well as 2 regular hospital units that would become step-down units. And so if you have completely different processes in each of these areas, it's going to be a nightmare. And so we've had a daily phone call between all of the ICU leadership in terms of like what the processes are going to be, and then, you know, assigned a couple of individuals. There's in terms of PPE, other things to think about are like a lot of these procedures use ultrasound. And so like, how do you then cover the ultrasound, not just the probe, but the whole machine, so that you can use it from patient to patient. We've also double roomed a lot of patients. And so how do you then, you know, say you're going to check C. diff on one patient and the other one is not being checked, then like, how do you then manage that? So there's been a lot of stuff that we've learned kind of along the way in terms of how to do it. In terms of daily activities, so we've tried to limit the number of providers that do the exam. So we usually just have one provider going in to do the exam. And ideally that same provider has both of those patients in that room. And so that we've limited number of exams. Any patient that recently got admitted or transferred, I've been the one in the unit to like walk in and see them, just so that I can get to know what's happening. If they have wounds, or like we've had somebody with a sacral decubitus, I wanted to examine it and take a look at it, being the surgical member of our team. But you know, you don't want to have everybody get exposed multiple times. In terms of PPE, we've also done a lot of conservation, where we take the N95 mask and we've been decontaminating them. And so at the end of your shift, you would then put it in a brown bag with your everything labeled, and you put it in like a main area, and that gets decontaminated. So when you come back for another shift, then you can pick that up and reuse it. There's also a face shield that we use on top of the N95 mask to prevent the N95 from getting any kind of droplets over it, to try to increase the length of use. That face shield then gets wiped down after each visit with one of the bleach wipes. What else? Meghan, do you have?
Yeah, I think a couple of key points that he mentioned. First is really trying to limit who's in the room. So while these are ICU patients who require a lot of intensive care, we're trying really hard to limit blood draws as much as we can, who needs to be in the room. And if you decide that you want something done, you know, you want labs at noon, but then maybe you want something at 4, you sort of pick one of those times and get everything done at the same time. Again, trying to limit the number of physicians who go in the room and examine patients. So at most sort of one person, maybe once a day, unless there's an acute change. Really it's the nurses and the RTs who are doing 95% of the bedside care. And we have, in some ways the luxury and the privilege to not have to go in quite as much. But I think batching care, batching labs, we are not able to get a lot of bedside studies done. It's sort of interesting which departments are willing to do it and which our vascular access nurses have been amazing. So they're coming up and putting PICC lines in if we need them. We had a bedside IVC filter placed yesterday by interventional radiology in one of our patients who has lower extremity DVTs and can't be anticoagulated. But what's been really hard to get are DVU studies to actually document clot, as well as transthoracic echocardiography. So we've been doing our own bedside TTEs. So it's sort of interesting how differently you begin to practice and how thoughtful we're trying to be about how many times we're going in the room and what needs to be done at different times. In terms of some of the sort of nuts and bolts about taking care of these patients, so by the time they come to us, they're either on significant high flow support, which we have been able to do because the RICU, our regional isolation unit, is a fully negative pressure unit. And then we've added HEPA filters and created a lot of negative pressure rooms. So I know the early recommendation, and in the slide deck, people will see that the goal was to avoid high flow nasal cannula. We are actually using a fair amount of high flow nasal cannula, partly because some of the data suggests that if you do require intubation, your mortality is exceedingly high. So whereas I think the initial recommendation was intubate early and avoid high flow, now we're trying to find a happy medium between that, which is if you can manage on high flow, keep them on high flow, obviously with some increased risk in terms of is it aerosolizing. We've been lucky here that we're doing okay on PPE with some attempts to try and conserve it, as Dr. Gadepalli mentioned, in terms of reprocessing N95s. But we have enough gowns, we have enough face shields, we have a fair number of PAPRs. So PPE has not been an issue at our institution, thankfully, at this point. But we are trying to avoid intubation if we can. We're proning patients before they get intubated. There's been some good anecdotal evidence that even proning people before they're intubated can potentially keep people from having to be intubated. As he mentioned, once they're intubated, I've been going really quickly to high PEEP, 18 to 20. I agree with him, very small changes, really trying to work on getting the FiO2 down before I start weaning PEEP. And that small changes and changes sort of once a day, almost like how we wean vents on our CDH babies, which we're really conservative with. Is kind of the same thing here, is just very, very slow moves. And once I get the FiO2 down to about 40 or 50, I start going down on my FiO2 by 5s instead of by 10s. But they're exceedingly hypoxic, tend not to have as many issues with ventilation, but very PEEP responsive in general. We've used paralysis a fair amount. The sort of 3 keywords I gave to the rest of our pediatric surgery group here was PEEP, proning, and paralysis. And early use of proning and paralysis has rescued a couple of our very hypoxic patients. And we use a fair amount of proning at Michigan anyway, so the nurses are fairly familiar with it. But obviously, you have to take a lot of things into consideration when you're thinking about proning patients and making sure that the nurses and the RTs feel comfortable, making sure that you have enough people to do it. And again, so it's a balancing act, right? Because you probably need 4 to 5 people in the room to safely prone a patient. And obviously there's the concern of inadvertent extubation. We've had lines pulled out during proning. So it's certainly not something to be taken lightly. But we've had some good success with some of our more severely ill patients with proning, and we tend to do 16 hours at a time. So that's something that has been beneficial.
Yeah. We also group the line placements. So as soon as they arrive, they get all their lines done at the same time. So they get a arterial line, a triple lumen central line, or a PICC line. But typically we've been using the left IJ to keep the right preserved for dialysis access if needed for CRT or intermittent hemo. And then they all get Foley catheters so that you don't have to change or go in there frequently to change them with the known risk of UTIs. And then they all get Dobhoff tubes for NGs for feeds, and they get on goal feeds very quickly. And many of them have been on like Nutrin 1.5. So the volume has been lower to try to make up the calories. And in terms of sedation, we've been trying to avoid benzos. So many of them have been on dexmedetomidine as well as propofol. And the propofol gives you a fair amount of calories. And so the total volume of calories for their feeds drops off significantly. And then every one of them has that's been intubated has been on restraints because they don't want inadvertent extubation. So it's been kind of challenging to kind of manage that and make sure that they have their restraints on, they're properly secured, that it isn't like, you know, done harmfully. And then some of them have required like interpreters, and so that's also hard to like do the conversation. And so there's a phone that's dedicated for the room where it's like for internal use only, and that has like FaceTime option on there, and it has like a call option on there. And so we've just been using that to like have the families converse with the patient by FaceTime. And so they might be intubated, but then they're conversing with their family because primarily it's bad lung disease with some kidney dysfunction, heart dysfunction secondarily. But trying to bundle all your procedures and lines up front, I think is very useful because once they're in, then you're good, and you can limit the number of times you have to go in there. The whole goal has been to like decrease healthcare worker exposure, and so there's an actual safety monitor that's in the hallway that is constantly roaming around and looking to make sure you're donning and doffing okay. My first night on, I watched the video, I looked at the pictures, but I sucked at it. And the safety monitor like just pulled me aside and was like, okay, we're gonna redo this again. I'm gonna have you practice this, and like until I got it right. And then when I walked out of the room, just stood there and watched me undo everything properly, and was like, okay, good. Now, you know, the next one you're gonna do without me standing over you. And like, it was like, it took me a while to get the hang of it. And it's like, it sounds dumb, but like I've seen the video like, I don't know, 20 times, and I still feel like until you do it a few times and know how to do a good job of protecting yourself, it's hard to do. And everyone looks at, there's always a buddy in terms of like making sure if the monitor is not there. So the monitor wasn't there in the middle of the night, and so you buddy up with someone so that they're watching you donning and doffing as you go in and out of the rooms, so you protect each other around it. As soon as you come out of the room, you go back to a regular standard face mask. And so face masks are given out as soon as you walk through the door for the whole hospital, and you just keep it for the day. And at the end of the day, you turn it in and, you know, wash your hands. The University of Michigan Pharmacy made up own bottles of like Purell. Basically, it's isopropyl alcohol, like 75%. And we've just been using that and just recycling those bottles to try to preserve a lot of it.
Yeah, we have a microbrewery make it for us just because they can make just about anything. I'm actually interested in the heparin that you guys are giving. Are you doing that like when they're still mild? Is it unfractionated heparin or Lovenox that you would use?
So we are using a lot of heparin drips. So if we document clot when we're going to put their lines in, then we have two different nomograms within the institution. One is our DVT-PE nomogram following 10 A's with a goal of 0.3 to 0.7. The other, so that's one population that's been getting the heparin drip. The other population is we're checking D-dimers on all of these patients. And on some of them, they're coming in with D-dimers in the double digits. Those patients were empirically putting on heparin drip, but at our acute coronary syndrome nomogram with a goal 10A of 0.2 to 0.5. Okay. And then if we've been monitoring the D-dimers daily for the first couple of days, and if they start going up, then we put them on the ACS nomogram as well. So it's sort of three different populations: documented clot, those whose D-dimer starts high, or those whose D-dimer starts increasing. We put on a heparin drip. Otherwise, we are trying to use Lovenox for prophylaxis, but the rate of acute kidney injury and acute renal failure is quite high, which makes it a little bit limited, either because we're causing the AKR or they're coming in. We've been pretty aggressive with CRRT in our patients, but it's interesting because when you actually sort of look back, a lot of these patients are coming in having been quite ill at home for the better part of a week or so, often with diarrhea, not eating. And so they're coming in with a mild to moderate AKI. I actually, in the past 4 days, only admitted one patient. Otherwise, all my other patients were pretty stable. And he came in and we spent sort of the first 24, 36 hours very gently hydrating him, using a lot of albumin to try and keep the volume low, and then sort of stabilized him out. I think his FiO2 only went as high as about 70, but his PEEP was as high as 20. And then after about 48 hours, we've started some very gentle diuresis just with Lasix and Lasix drip. And his creatinine is still normal. But I think of the 12 patients that I've been taking care of, at one point I had 5 on CRRT. And I think some of it is that they're coming in dry. I think we're also trying to keep them certainly on the drier side. But those are kind of, yeah, a couple of pearls in terms of the heparin drip. We've been really aggressive with starting heparin, partly because we were clotting off CRRT machines left and right. And seems like every time we've looked for a clot, we found it. So, and also part of me wonders if some of the sort of sudden cardiac death that we're seeing in these patients is actually from PE. Right. So we have probably half of our patients, half to 3/4 of our patients are on heparin drips.
Meghan,